Thanks, Joe. Thank you for the invitation. And these are my disclosures. My task is particularly tough. First of all, I'm going to be debating against a very tough opponent. And I am going to be speaking for some tests that most of you do not do in your routine practice. But I'm going to be a straight shooter. I won't confabulate. I won't exaggerate. So the reality is that MRD is as ready for prime time as these talk shows are. I'm going to ask for you to focus just for 15 minutes or so that I have, because I'm going to tell you the facts. And then for the subsequent 15 minutes, you can probably zone off. So about 2 decades ago, MRD testing was in its toddler stage. Dr. San Miguel from Spain had actually already shown in 2002, 2003, that MRD negativity was associated with superior progression-free survival and overall survival. And this is where MRD testing is today. Just because we haven't learned how to use MRD in all the possible ways doesn't mean that we cannot use it today. In fact, if you think that testing for CR is important for your patients, testing for MRD is as much important today because MRD is the new CR. And MRD actually stands for minimal residual disease, the amount of disease that remains, or amount of myeloma in this case, that remains in the body after therapy. And the analogy that I use is this finding a needle in a haystack, kind of 1 in 10 to the power 5, 100,000 cells or 1 million cells in the marrow. So if the test can detect 1 myeloma cell, that would be a very sophisticated test. And the iceberg analogy is what we use very often for the myeloma tumor burden. And in the interest of being fair and balanced, here you go. But what we do know in myeloma, the deeper the response, the longer the time to progression, as you can see here. And now we have more sophisticated tools, and those tools are next-generation flow and next-generation sequencing. So what exactly is next-generation flow? So next-generation flow is actually taking into account the EuroFlow SOP, or standard operating procedure, with a sensitivity of at least 10 to the power minus 5 if 200 million events or cells are collected. And actually, it can go up to 10 to the power minus 6 if 10 to 20 million cells are collected. And what the lab typically uses is 2 tubes, and these are the antigens against which fluorochrome and conjugated antibodies are used. And the advantages of MRD testing by next-generation flow is that it is very rapid. It has to be performed within 24 hours of sampling. And it can even detect if your sample is good enough, because it can detect the quantity of erythroblasts. It can detect quantity of precursor B cells as well as mast cells, and tell you if your sample is good enough to actually perform the test. Now here on your left, you can see actually dot plots of a patient who was initially told that he was MRD negative. This was on a test that had a sensitivity of 10 to the power minus 4. But on further analysis with a more sophisticated test of 10 to the power 5 minus 5 threshold, you can see that myeloma cells, these red dots are detected, and you can see the normal cells, normal plasma cells are the blue dots, which are at times difficult to separate, but the red dots on certain scatter diagrams here are very distinct population, and in this case, 2 cells per million cells analyzed in the marrow were detected. And the other tool is the next generation sequencing. In fact, this tool actually takes into account the VDJ segment rearrangement concept, which we all have. And in particular, myeloma cells have a particular clone that can be detected both at the time of diagnosis and with sensitive tools at the time of testing post-therapy. And after the DNA is extracted, it is amplified by PCR using consensus primers, and then sequencing is performed on a next-generation sequencing-based platform, following which there is grouping and merging of sequences to distinct clonotypes that can then be compared against reference germline sequences that are available. And then you have to look at the diagnostic or the initial sample, and it may not always be diagnostic sample. It can be any sample for that matter that has certain amount of tumor burden, because then you can identify the clone, and subsequently for MRD monitoring, you can search for that same clone that you have identified in the diagnostic or characterization sample. It is, in fact, Clonoseq is FDA approved for MRD testing in myeloma. And what's more, it is now paid for since January of 2019, paid for by Medicare. In fact, the revised International Myeloma Working Group response criteria have now sub-categorized CR response into flow MRD negative. It's by next generation flow, or sequencing MRD negative. The third one is imaging plus MRD negative, either by flow or by next generation sequencing. And in this case, the imaging is PET-CT scan. And the fourth one is sustained MRD negativity, in which case the imaging plus the NGF or NGS is used, but the thing is confirmed 1 year apart. Now, we had shown a long time ago that not all CRs are same. In fact, stringent patients who have achieved stringent CR after autologous stem cell transplant are the ones that truly do much better than the ones who are in CR or near CR. But that was a long time ago. Now, in fact, the Spanish group has shown that if your patient is in CR, it is very, very important to find out whether the patient is MRD negative or MRD positive. Because look here, the MRD positive CRs are as bad as PRs. So you are actually misinforming your patients that they are in CR and giving them a false sense of hope if you do not take into account whether they are MRD negative or MRD positive. And in this cohort, actually, MRD negative patients who had an MGUS-like immunophenotype to begin with did much better. In fact, their 10-year overall survival rate was 94%. Now, you've heard from Dr. Kaufman about this IFM 209 study that actually had lenalidomide in the maintenance, had used lenalidomide alone in the maintenance setting. And post-maintenance MRD was assessed initially by flow, and this was just conventional flow, not the Euroflow I talked about, and had only the sensitivity of 10 to the power minus 4. But when these MRD negative patients were reassessed by next generation sequencing, 51% of MRD negative patients were actually MRD positive by Clonoseq. So both tests are correct, but you have to first look at what the sensitivity of the test is. So when you're actually sending the sample, the first thing you have to look at if you find the sample MRD negative is what the sensitivity of the test is. If it is 10 to the power minus 4, it may be MRD negative for that test. But if you look at it with a more sophisticated tool like a next generation flow or next generation sequencing, the patient can have MRD positive result. And as you can see on the right side, with Clonoseq, the more the tumor burden, the poorer the poorer the outcome. And in fact, a meta-analysis has already shown that patients who are in CR do much better if they are MRD negative compared to those who are in MRD positive state. And this is pooled individual data analysis. On your left side is the impact of CR on overall survival. And here's the course of a patient with multiple myeloma that I've been treating since 2013. Look at the number of therapies this guy, who's 72-year-old with IgA lambda translocation 1114, multiple myeloma, has received. CyBorD, autologous stem cell transplantation, following which he was on VRD therapy, followed by Darapom-Dex, ixazomib thalidomide dex, ixazomib Pom-Dex, and ultimately venetoclax through a clinical trial. And the drug that Dr. Martin talked about, the GSK 916, following which he was in MRD negative, just a couple of cycles of this agent. And imagine the look on this patient's face when he came to know that for the first time he was MRD negative. Mind you, he had 90% bone marrow plasma cells at the time he entered the study. And this is the data from the IFM 2009 protocol, where MRD testing was performed both before maintenance and after 1 year of maintenance. And this graph actually shows the outcome of patients based on their MRD status prior to the maintenance. And you can see patients who had MRD negative status and had undergone transplant, or RVD alone, that is, they were in the other arm, their outcomes were pretty similar. As long as they were achieving MRD negative status, outcome was good, but those who were MRD positive didn't do as well. Similarly, for the high risk versus standard risk patients, it didn't quite matter. Even for the high risk patients who were MRD negative, they did just as well as the ones who were standard risk and MRD negative. The PATHEMA GEM 2012 protocol actually measured MRD at different time points. They assessed after 6 cycles of VRD induction, after transplant, and after 2 cycles of consolidation following transplant. And what they found was that the MRD positive rates were much higher in the high-risk patient population, and the MRD tumor burden was much higher in patients with deletion 17 compared to standard risk patients. And this was quite comparable in the translocation 414 and standard risk population. And here's another example of a patient I've been treating for the past year and a half. This is just a 42-year-old male with IgG lambda multiple myeloma, had 60% bone marrow plasma cells at the time of diagnosis with deletion 17. And his diagnosis was in October of 2017. He was refractory to VRD, so it was changed to DARA-KRD by his hematologist, and then he was referred to me for autologous stem cell transplant. So post-induction therapy, i.e. pre-transplant, he had less than 5% bone marrow plasma cells. After first transplant, and he went home in just 18 days, day 100 marrow showed that he was MRD positive, and this was by flow that we routinely do at Mayo Clinic in patients who are in CR. Not all patients, only the patients who are in CR. He went on to get the second auto stem cell transplant as part of tandem transplant approach, and on day 100 of second transplant, he was MRD negative, and what's more, he was PET-CT negative as well. Currently, based on the Tourmaline-3 data, he is on a PI-based consolidation therapy, because we know that maintenance consolidation is even important in patients who are MRD negative. So we were not changing therapy, but imagine how this patient felt. And in fact, if you look at the results of this Spanish trial, the MRD testing, based on the MRD testing, this patient, who was very high risk to begin with, and obviously was showing all the high risk features, his prognosis, and obviously I can't tell you right now because it's early in the disease course, but I showed him this graph, and his prognosis is just as good as any standard risk patient who's MRD negative. And you can see the fluorescent green line is actually showing outcomes of such patients who have 90%, 89 to 90% 3-year progression-free survival, even if they are high risk. Now, the importance of MRD negativity is also established in the transplant-ineligible newly diagnosed myeloma patients, as was noted in this MAIA study, where there was evidence of 3-fold improvement in MRD negative state with DRD compared to RD alone. What's more, it is useful even in relapsed refractory population. And here you can see actually serial measurements of MRD was important because both in Pollock's study, which you just heard about, as well as Castor study, the patients who had achieved CR and had sustained MRD for at least 6 to 12 months did much better compared to those who had ill-sustained MRD negative status. So it is important not only to perform following initial therapy, but also continuing to check for MRD if you believe your patient is in CR. But it is also important to note that that is not enough. Performing tests or analyzing just the bone marrow alone is not sufficient. In fact, patients who were MRD negative in this Imagem study by bone marrow flow cytometric analysis, about 14 out of those 86 patients were PET positive. But the ones who were PET negative as well as MRD negative by flow cytometry did much better than the rest of the cohort. In fact, at Mayo Clinic, there's this data management center for surrogacy analysis that is currently going. This is an independent international team that has been established for endpoint approval of myeloma as myeloma minimal residual disease. It's called the I-Squared team, comprises of clinicians, statisticians from FDA, from academic centers, as well as the industry. And the whole goal is to validate it as a surrogate endpoint so that it can facilitate formal FDA EMA qualification of MRD as a surrogate endpoint for future myeloma trials. This has not been done yet, but we would have results of this probably in late 2019. As an example, I've shown you here that MRD can be used if you look here for relapse refractory patients with standard therapy, standard of care in one arm versus experimental therapy plus standard therapy. And if you can establish MRD difference early on, and if it is established as a surrogate marker, this can lead to accelerated drug approval. I'm not saying that you don't have to look at other other endpoints such as PFS difference and overall survival difference, which can occur later on during the disease course, but those would be sufficient for regulatory approval. But for accelerated approval, once we can show the FDA that independent of the patient methods, whether it's next generation flow or next generation sequencing or patient characteristics, we can use MRD as a marker of clinical benefit. Dr. Rajay actually alluded to this trial, the Optimum study, where the escalation of therapy in MRD positive patients who have already received 1 year of lenalidomide maintenance therapy is being assessed, and one arm the therapy is intensified by adding ixazomib to lenalidomide versus lenalidomide and placebo only, just continuing that same old lenalidomide. And we don't have the results of this trial yet, but this will tell us if we can use MRD in more than one way. So what I have told you right now is that MRD can be used in the response criteria and must be used today. In fact, IMWG has already established it as a response criteria. Methods like NGS and NGF have already been standardized, and it is an important prognostic marker. It has not been used as a regulatory endpoint yet, but the surrogacy analysis is ongoing, and the early readouts would be in late 2019. We cannot yet tailor therapy based on the MRD status, but hopefully we would have that in near future as well. But there are many other things that need to be answered. What exactly is going to be the impact of MGUS-like profile in patients with MRD negative status? How to define the exact interval of sustained MRD negativity? IMWG response criteria say 1 year apart, but the longer you are MRD negative, the better the prognosis. We still don't know if PET is the optimal imaging for MRD assessment. There are many other tools that are being used. There are blood-based MRD assessment assays, as well as detection of clonal evolution, which is more easily detected with next-generation sequencing compared to next-generation flow. And with that, I would end. Thank you.